In the EAN ILAE International League Against Epilepsy joint symposium here in the European Academy of Neurology Congress in Helsinki, I discussed about palliative care in severe epilepsies, rare and complex epilepsies. Do we need that? And my view is that we definitely need that, and we have not been talking about enough about it, and there are many misunderstandings about it, even among neurologists and clinicians, and let alone then, of course, patients and families. And we should start to define better palliative care in these patient groups, but also we really should start to discuss with patients more about it, and perhaps even in more advanced stages of the disease, so that we could get the better understanding of this kind of treatments. It's not dichotomous that first you actively treat and then you stop the active treatment, but it's more sort of used to integrate the symptomatic treatment, palliative care, to the active treatment during when the disease becomes more progressive, and that would also prevent the burnout in the healthcare providers, professionals, and also the families, and also increase the quality of life of the patients. I think the problem, one of the problems and challenges why we don't usually nowadays bring up palliative care possibilities in our patients is that we don't have enough proper tools of prognostication, and we don't know to whom and when to start to talk about it. And first of all, of course, in future probably we would have better multimodal neuroprognostication. We would have biomarkers for prognostication. We would have genetic tools, and we could combine different kind of biomarkers. But it's very individual. And first, you of course need to know your patients. We would need to have continuation of care. We would also need to have multidisciplinary teams, and you should not do these discussions and decisions yourself only alone. But I'm really confident that it would also, as said, it would decrease the burden of the care for all the stakeholders.